All right. So I will go ahead and get started. I am a general pediatrician, an addiction medicine physician, and I work in Boston at Mass General Hospital. And I'm the medical director of a clinic that cares for families impacted by substance use disorder from conception of pregnancy through early childhood. I am so impressed and inspired by your state's month-long commitment to highlighting the importance of opioid-exposed dyads and addressing the issue of neonatal abstinence syndrome, and thrilled to be part of a really wonderful group of people who've already spoken before me. All right, just gonna move So during my time today, I'm hoping to review the existing trends as well as some of the limitations of our existing prevalence data around substance use in the perinatal period, highlight the importance of a continuum of care for women and their families across the perinatal period, and then describe our efforts to develop a multidisciplinary and co-located clinic to care for families impacted by substance use disorder. And during that time, discuss the unique stigma of mothering and parenting with a substance use disorder, and specifically addressing what happens when recurrence of use to substances occurs. Please feel free to interrupt me with questions anytime. I hope that this is a conversation, and I've left a good chunk of time at the end to hear from you all. And I just want to say that as part of my learning and development of this work, I've relied on the giants in your state, learning from the work from the Mommies program, from Lisa Cleveland and others. And so it's a real privilege to get to share this with you. I thought I would start off by presenting this data from Lindsay Adman and her group that was published in the American Journal of Public Health last year. She was able to look at trends in both amphetamine and opioid use among pregnant women at time of delivery. And I think it's important, as we focus on opioids, we also think about the rising context of other substances that are occurring, and then also the geographic differences. So you can see here the kind of growing disparity in opioid and amphetamine use in rural versus urban communities. Here's just some basic kind of prevalence data for you. This is not news, I'm sure, but there's been a rise in the rate of neonatal abstinence syndrome or neonatal opioid withdrawal syndrome across the country, from a little bit more than 1 per 1,000 deliveries in 2000 to now close to 7 to 9 per 1,000 deliveries, depending on location and where you live. I wanted to put Texas data that I was able to get in the context of the national rate, and you guys actually have a lower rate than what we're seeing across the country, and certainly what we see in New England, where those rates get into the double digits, and highlight kind of the work that your state has been doing. But I also wanted to take a minute and make the point clearly that a rise in cases of neonatal abstinence syndrome or neonatal opioid withdrawal syndrome may in fact represent an increase in the women who are using opioid medication treatment for opioid use disorder. And so I wanted to share this diagram with you to make this point. Our goal during pregnancy is to move women from using non-prescribed opioids into treatment of opioid use disorder with either methadone or buprenorphine. But there's really a whole host of different medications or substances that can cause withdrawal symptoms. So it could be prescribed opioids for chronic pain. We know that some other psychiatric medications can have a withdrawal syndrome. And when we just look at those national prevalence data, we don't know which of these buckets women are infants have been exposed to women taking which of these medications. And so we want to ideally make this circle smaller and this circle bigger. And that may mean that for some time, the rising rate of neonatal abstinence syndrome is actually more women engaged in treatment, and that's not necessarily a bad thing. I also wanted to highlight the lack of linked maternal and infant health data that really complicates our public health reporting. So this is data from the same source from the Healthcare Utilization Project, overlaying the deliveries to women with maternal opioid exposure and the rate of neonatal abstinence syndrome diagnosed during these deliveries. These data don't talk to each other, they're not linked. And so we actually don't know the sort of total number of opioid exposed infants that exist until our public health data has sort of better communication with each other. And so let me show you what that could look like. And maybe this is sort of a call to action in your state for really thinking about how we present the information around the prevalence of NAS. This is data from Tennessee. As you can see, similar to what we looked at across the national trends, they're seeing a slight rise in the total number of cases of NAS among all births. But if you break that data down and you look at actually the type of exposures that led to those cases of NAS, what they've really seen is over the last 5 years, or the 5 years in this data, they had a rise in the number of women who received only medications to treat opioid use disorder, and a decrease in the numbers of individuals who were using only non-prescribed substances. This is what we want to see. And until we're able to really link our data and present the sort of combination of what types of exposures lead to rising rates of NAS, I think we're missing part of the story. I also want to challenge you and us during this month to really think beyond NAS. So NAS is really an important touch point that we have as medical and clinical providers in the hospital to address perinatal substance use. But really there's many other important touch points, including pre-pregnancy in terms of preventing undesired or unwanted pregnancies or unintended pregnancies, the prenatal period, and then after birth, including the neonatal period and early childhood. I really like this schematic by Stephen Patrick, a colleague in Tennessee. I would add that the postpartum period for mothers is a really critically unique, important time, and I'll present some data as to that as we go forward. I also want to emphasize that while we're focusing on opioid exposure today, that there's really a whole host of much more common substances that have much more long-lasting and detrimental impacts to the growing fetus, including tobacco, alcohol, and other drug use that really are much in much higher numbers than in utero opioid exposure. So it's important as we think about what services we can develop for these families that we're also really thinking about the impact of other substance exposures. All right, I'm going to shift towards thinking about prenatal engagement. This is a diagram that's adapted from a colleague, Mishka Turplin, and he really kind of highlights that pregnancy is the intersection of your addiction lifespan and your reproductive lifespan. And I think it's important, and it's the reason why myself as a pediatrician became really interested in this topic, is thinking about how it can be a uniquely motivating moment in a woman's life for thinking about engaging in treatment. This is likely a review to all of you, but I just want to make it clear that the treatment for opioid use disorder and pregnancy that is recommended is actually the treatment that we recommend for all individuals with opioid use disorder. That methadone or buprenorphine is seen as the standard of care combined with behavioral therapy. Our ACOG, American College of Obstetrics and Gynecology statement is quite clear on this, that pharmacotherapy is preferable to medically assisted withdrawal because withdrawal is associated with high relapse rates, which leads to worse outcomes. I took this from your Texas NAS Month Awareness aim, which is wonderful to sort of see this be a focus, that pregnant women using opioids should not discontinue opioid use due to the risk of maternal relapse, overdose, withdrawals, and fetal distress. I thought I would turn to a case for a few minutes. So Kelly is a patient in our clinic. She's a 34-year-old Black non-Hispanic woman who's experiencing her first pregnancy. She has a history of polysubstance use, including cocaine and opioid use disorders, tobacco dependence, and she's presenting late to initial prenatal care at 34 weeks, where she's been actively using non-prescribed substances throughout her pregnancy. She has a history of Child Protective Services involvement herself as a child, and her parents both struggled with active substance use disorder during her childhood. And she presents to care in your clinic and desires a healthy pregnancy, but remains ambivalent about starting medications with either methadone or buprenorphine. So why do pregnant women avoid treatment? I think what we've seen is that there's a clear desire to minimize exposures to the fetus, to avoid the risk of neonatal withdrawal. As much as I tried to convince you that there are cases of NAS that are expected, nobody desires to watch their infant experience symptoms of withdrawal. There's shame and stigma of active drug use during pregnancy. There's a desire to avoid Child Protective Services reporting. because there's a real fear of punitive responses. And I think that there's also historical and community views that differ by medication treatment. And what we found in the study that I'll share with you next is that there's also differences by maternal race and ethnicity. So this is a schematic from a paper that we published in JAMA Network Open about a year ago. And we set out to answer the question, were there differences by maternal race and ethnicity in the use of methadone and buprenorphine medications for the treatment of opioid use disorder during pregnancy? And we looked at two different kind of outcomes. The first is on the left, in the dark blue, did pregnant women receive any medication? And then in the light blue is the percent of women who consistently received medication. And in our adjusted models, we found that Black, non-Hispanic, and Hispanic women were 58 to 63% less likely to receive any medications. And they were 66 to 76% less likely to consistently receive medications compared to non-Hispanic white women during pregnancy. And I think this is really important as we think about areas for us to potentially target in terms of focusing on treatment and disparity and equity. The other area that I think we, as a medical community focused on addressing the stigma from addiction, particularly in the prenatal period, can utilize is shared decision-making to aid in making decisions around medications to treat opioid use disorder. So this is where those motivational interviewing skills of rolling with resistance and developing discrepancy to try to understand why people prefer to take one medication or another, or prefer not to take a medication. There's a really nice tool that was published by Connie Gill at the Medical University of South Carolina that you can use with your patients to help walk through what their preferences are, and then come to a shared decision-making with your patients. All right, I want to shift to some postpartum risks. I really like this quote from the peer recovery coach in our clinic, where she says, the truth is, getting through the pregnancy is actually the easiest part. This is data that we have in Massachusetts that looks at the opioid overdose rates, both fatal and non-fatal overdose rates among pregnant and postpartum women in Massachusetts from 2011 to 2015. Again, this is using a really wonderful linked data set that we have from our Department of Public Health. And you can see as you progress throughout your pregnancy, the rate of overdose events decreases or declines as you get closer to delivery. And then in the postpartum period, particularly the 6 to 12 months following delivery, you see a real bump in those opioid overdose rates. When you stratify that by whether women were receiving either methadone or buprenorphine the month that the overdose event happened, you can see that overall, there seems to be about half as likely rate of having an opioid overdose if you are on medications to treat opioid use disorder, but that those numbers may be less protective in the 6 to 12 months following delivery. Although these are small numbers, overdose is still a rare event, and these are wide confidence intervals. So I think we still have a lot more to learn about that period, 6 to 12 months postpartum, which again speaks to the need for us to extend the services and the care that we provide beyond what is traditionally considered, that perinatal period ending at 6 weeks postpartum. So why are postpartum women vulnerable? I think that there's a loss of access to specialized services that are designed to care for pregnant women. So as we talked about in many states, I'm not sure specifically about Texas, but Medicaid services for women may end at 6 weeks postpartum. There's high rates of postpartum depression among women with substance use. There is a great amount of shame and stigma that women feel watching their infants experience symptoms of opioid withdrawal. And that's all in addition to having the stresses of having a new baby. There's heartbreak that can occur if you're separated from your baby with loss of parental custody and a strong desire to discontinue medication treatment. And another study that we did using that same public health data set in Massachusetts, we looked further at the overdoses that happened in the year following delivery. And we identified 189 overdoses among women in Massachusetts between 2012 and 2014 that happened a year following in the postpartum year. And interestingly, less than half of those women who had an overdose were those that had a known diagnosis of opioid use disorder anytime in the year during their pregnancy. And so I think what that shows me is that we have a real opportunity in the postpartum period. So for those of you that are pediatric providers, clinical or community providers, social workers who are working with families after they're discharged home from the hospital, we have an opportunity, but it really requires parental trust and non-punitive responses to helping support families when they're struggling. The final bit of data that I wanted to share with you is a look at the discontinuation of medications. Again, this is all Massachusetts data, but overall, this is what we call a Kaplan-Meier survival curve. And so the 1 over here means that everybody on month 0 was receiving medications to treat their opioid use disorder, which is at time of delivery. And then 12 months later, we found about 60% of the sample was still receiving medications to treat their opioid use disorder. And I want to show you this stratified by a couple different things. The first is that we didn't really see any clear difference, whether you were receiving only methadone or any buprenorphine. But we did see differences again by maternal race and ethnicity. And so I think that this is notable to say that those individuals who are of non-white, non-Hispanic race were, who were white, non-Hispanic, were more likely to maintain on their medications than individuals of other races and ethnicities. And then the final clear factor was around the degree of medication use during pregnancy. So this doesn't strike anyone probably as a surprise, but if you were on medications all of your pregnancy, you had a much higher likelihood of maintaining those medications in the year postpartum compared to individuals who were on 4 or fewer months. There was a more than 50% drop off in that year following delivery. I think this also speaks to a group that we have an opportunity as a public health and medical community to potentially target. Okay, shift for a second to thinking about addressing the stigma and then recurrence of substance use while parenting. This is data from ProPublica and the Guttmacher Institute that really highlights the punitive policies towards substance use in pregnancy. So Texas is, you can see a state here that's shown in red where Guttmacher has determined it to be a state where substance use during pregnancy is equated with child abuse. You can see here that there's even a larger number of states that have had women experience prosecution for their drug use during their pregnancy. And that's despite the fact that really all of our national medical and public health organizations have talked about the importance of not prosecuting pregnant women with substance use disorder. And that's because it drives women from prenatal care and substance use treatment, and it risks poor outcomes for both women and their children. This is a snippet of the ACOG statement, and I was really lucky to work with Stephen Patrick on the American Academy of Pediatrics statement, which clearly affirms the need for a public health response to opioid use in pregnancy. This was an article that was in the New York Times now almost 2 years ago, more than 2 years ago, highlighting, again, the unique stigma that pregnant women who use drugs experience. This was a patient who was one of the early patients who was cared for in our clinic at Mass General. This expose, if you haven't read it, really chronicles the stigma and then the discrimination that pregnant people using drugs experience. And so what's the result of that stigma? The result of that stigma is that there are a greater number of people who are parenting who it seems like are potentially not engaging in the recommended treatments. This is a paper by Kenneth Fetter when he was at the Johns Hopkins School of Public Health that looked at barriers to engaging in treatment among adults living with opioid use disorder who have children in their home. And as you can see here, among adults with unmet treatment needs, those who are living with a child in their home compared to those who do not had 2.9 times the odds of reporting treatment access barriers and 4.1 times the odds of reporting stigma being a barrier to them engaging in treatment. I think it's really notable that overall, among adults with opioid use disorder, only 27% of those who are living with a child reported any past year treatment. So this really speaks to the opportunity that, again, the hospital period while monitoring and caring for infants with NAS is a potential touch point, but so is the postpartum period, and that you as potential pediatric providers outside of the hospitalization period have a real opportunity to support families during this time as well. Okay, so I previously showed you the really nice diagram from Mishka Turplin, and I've made it really messy and sort of turned it on its head in thinking about what happens with parenting. So while the intersection of addiction and reproduction lifespans is pregnancy, the intersection of your addiction and parenting lifespan happens at substance use recurrence. And one of the hardest things that we do in our clinic, which I'll describe a little bit more about in the next section, is how we address ongoing substance use recurrence while parenting. So we know that addiction is a chronic relapsing brain disease, but if we're really going to treat it as such, how do we create safe policies to address ongoing substance use while parenting? So I wanted to share with you what we've come up with, because we've grappled and struggled with this a lot, is that when a patient is identified as using non-prescribed substances, either from self-report or toxicology testing, we perform a full safety assessment. And that safety assessment for us focuses on these 5 main domains. The first is, what's the safety of the child? So where are they when substance use happens? Who's caring for them? What is the parental engagement in treatment? And what is the safety of their use patterns? Are they using alone? Do they have somebody who's with them? Where are the works in terms of where are they keeping substances? And then their willingness to escalate treatment and services, willingness and ability to participate in self-care. And then finally, the stability of their home environment. And based on those 5 domains, we then make a decision with the patient around sort of the safety of the child in the home at that time. I really like this now old quote from the Massachusetts Family Recovery Collaborative, which was a sort of multidisciplinary group that existed now over a decade ago, that said, no one organization or system can address all the substance use challenges facing families and communities, that ensuring child safety and family health requires collaboration and partnership among families, professionals, agencies, organizations, and communities. And I like this to sort of speak to the necessity of us creating real strong networks to ensure families' safety and stability. Okay, the last section that I want to talk with you about is a little bit about what we're doing in our Hope Clinic and our attempts to kind of address some of the pieces that I talked about with you. So there are 5 core components that we've really rested our clinical program on. The first is that we were committed to providing multidisciplinary co-located care that was integrated care, not just for mother and child, but also for her partner. That the care would be longitudinal from conception of pregnancy through the child's 2nd birthday, and that care would be low barrier, meaning that we would meet people where they're at and welcome them regardless of where they were, and that care would be trauma-informed and welcoming. So when I first got to MGH now about 4 years ago, there was a lot of work that was happening in a number of different departments across obstetrics, our addiction, substance use disorder initiative, psychiatry, mental health, newborn medicine, and then pediatrics or internal medicine, primary care. But none of these disciplines really talk to each other. And so what we set out to do was to turn them on their head and integrate them and co-locate them. And we developed a high-touch model with wraparound support services, including obstetrical care, addiction care, perinatal psychiatry, social work, and pediatrics, that we had peer support that would be able to connect with women outside of our weekly Hope sessions, that there would be sort of support from a low barrier addiction clinic and wraparound care from a pediatric group practice and obstetrical group practice that provide care 6 days a week. And that prior to the pandemic, we had childcare that was available from our backup daycare at Mass General, which really was an incredible resource for women to be able to have a couple hours off from their kids to really focus and prioritize themselves, while also then getting their kids checkup care at the same time. I don't want to necessarily focus on the numbers here, but I did want to just share with you, and I'm sure it's very similar to the patients that you care for, that these are medically and psychosocially complex patients, that they often have significant housing insecurity, very low rates of monthly income. Many have had criminal justice involvement. Many have had prior pregnancies and prior pregnancy pregnancies that have resulted in loss of custody, continuous custody of their children, and that polysubstance use is the norm, with a significant number of individuals who've experienced prior overdose, that have family histories of substance use disorder, and have experienced medical complications from their substance use disorder, both hepatitis C as well as endocarditis. I think the rate of co-occurring psychiatric diagnoses has been almost universal, including depression and anxiety or PTSD. And more than half of the individuals we've cared for have had a prior psych hospitalization and or a prior suicide attempt. So we really have tried to focus on pregnancy being the kind of building blocks for developing recovery. It's an opportunity when women are motivated to optimize substance use disorder and mental health care, to lay the foundation of motivation, skills, and support that are needed, including longitudinal team care, building trusting relationships, peer coaching, which I'll talk about more in a second, linkage to community organizations, and then developing parenting skills and also relapse prevention skills. And finally, to address material needs. Our perinatal recovery coach at our clinic, this is Katie Raftery, who's been with us since the beginning of our clinic, has really been the glue. She's a person with lived experience of parenting and early recovery and offers a wealth of treatment system knowledge. She's able to spend time prior to COVID in the hospital, outpatient and community-based settings, and can be a high-touch contact for patients who present in crisis and offer unbiased, non-judgmental, and level-headed support. And she's supported by a larger recovery coach program at our institution, which has been critical. I wanted to end with just a few of the opportunities and challenges that we experience caring for families following discharge from the delivery hospitalization, where they may have been monitored or treated for neonatal opioid withdrawal syndrome. And we really focus on how you can think about supporting the diet in the early postpartum period. And the first is that for many of our patients, the early postpartum period is really focused on a number of infant medical needs. We do see persistence of withdrawal symptoms. So in my role as a pediatrician, I feel like the most common presentation for visits in the postpartum period are related to fussiness, some increased tone, feeding challenges, rashes due to increased stooling frequency. There's can be increased skin breakdown in the diaper area, and then a very high rate of sort of concerns around gassiness or just sort of fussiness in that kind of first 3 months of life. And then later there's kind of monitoring for risk of ocular comorbidities, hepatitis C exposure, and potential for developmental delays. But I think one of the places where we've really tried through our co-located model to support families and has been at times more successful than others is, what do we do when we talked about that relapse is an expected part of recovery, but when children are involved, everything really is a bit trickier. So for us, open communication with our community partners and providers is critical. We try to have tough conversations with DCF, our child welfare reporting agency, together with the patient. And if child custody loss was to occur, we do our best to promote shared visits following that loss of custody to maintain our parents' engagement in care should parental custody loss occur. All right, so in summary, I think I whizzed through that a bit. It's critical to take the time during pregnancy to lay the foundation for success postpartum, that longitudinal care across the perinatal continuum can help women engage in care and sustain that treatment following delivery. The integrated multidisciplinary teams can collaborate to address all of the vulnerable families' concerns at one time, and that meeting patients where they are at, bringing them to where they need to be, requires patient-centered and trauma-informed care. And with that, be happy to take any questions. Please reach out to me. My email is there, and I will stop sharing my screen so I can see all of you.
So we had someone just do a comment. They just said no questions, but thank you very much. They enjoyed your presentation.
Thanks.
So much great information in a short period of time. Love the information.
Thank you.
Can you share more about treating the partners of pregnant women?
Yeah, absolutely. Thank you for asking that question. And I think that this is, both challenges and successes. We have found that for many relationships, supporting their relationship and prioritizing the care of both the mother and the partner allows for greater engagement. Where it's complicated is that these relationships are also often very complicated. There may be a long history of intimate partner violence or potentially substance use coercion. And we now have the benefit of having a large enough team that we can have two different psychiatrists care for mom and her partner. That's been really important for us, particularly in the setting of sometimes concern for kind of safety. And if there is ever concern for ongoing or continuing intimate partner violence, we tend to try to sort of prioritize the birthing person, which is sort of the challenge that we're still struggling and working through. And I'd be curious to hear any of you guys in the work that you do have figured out additional ways to address the family unit. We do think in kind of the postpartum time, families that have a supportive partner and absolutely a supportive family are so much more likely to be able to thrive, which is why we've really tried to prioritize the importance of engaging both mom and partner in treatment.
We have a question. Have you had any opportunities to speak to government officials about making some changes to the law surrounding mom in these situations?
Yeah, so I really think of my role as a clinician researcher being a three-pronged role, which is that of a clinician researcher and an advocate, that you all in your kind of respective positions of power that you have an opportunity and also a responsibility to advocate for our patients who really often feel voiceless and kind of discriminated against by the system. So actually today, our state is hearing a bill for the first time that would remove the mandated reporting on medications to treat opioid use disorder in our state in Massachusetts. And so I actually am really hoping that my turn to testify doesn't happen during this hour, because sometime between 11 and 1 is when I will then, take off my sort of clinician scientist hat and put on my advocate hat and really speak to the importance of the need to change these laws. So I hope and encourage and would love to work with any of you in thinking about the opportunities within your state to move beyond some of our outdated interpretations of mandated reporting towards more supportive care for these families and a public health approach. Thank you for that question.
Another question. Do you have any written protocols, policies that clinics could use to start a program similar to yours? What resources did you use to get started? Any guidance on this would be appreciated.
Yeah, absolutely. I have told myself that by the end of the summer, we are going to have written up our model and have our sort of first 2 years of evaluation that we submit for publication for that purpose. But in the meantime, I'm happy at any time offline to talk about informally some of the lessons that we've learned. We were, I think, 2 or 3 pieces that were really critical to our success. One is that we got seed funding from our Medicaid ACO redesign in our hospital and across our state. So as accountable care organizations were forming, there were funds to think about how to co-locate and create sort of innovative models of multidisciplinary care that we capitalized on and that were grant funded. And so we received state opioid response funding through a program called Moms Do Care in our state that has allowed us to sustain the non-billable services that I highlighted to you today, and that unfortunately, until we've also advocated for a different payment model for reimbursement of those non-billable services that are really critical to our patients' and families' success, it's really hard to move things forward. So, and then the final thing is institutional buy-in. So there has to be individuals in your hospital who are willing to say that in order to really change these outcomes for these families that we're prioritizing, that your government has said is important enough that we're going to focus this month-long, effort to try to improve outcomes for, that starts with care before the delivery hospitalization. It really starts and continues across that whole perinatal continuum.
You have another question. They're not sure if you touched on this or not, but do you have a program with peer recovery coaches in the NICU?
Oh, great question. So we have a cuddler program that got sort of put by the wayside during COVID that we're hoping to bring back in kind of early summer this year. Those individuals who are volunteer cuddlers are not necessarily people in recovery. We do have a peer recovery coach who is able to support women when they end up kind of admitted for that delivery hospitalization. Although I love the idea of kind of developing a cuddler program that really prioritizes those individuals and who have lived experience. Great idea.
Another question, does your program have a relationship understanding with CPS custody issues?
Yeah, I think this is one of the more challenging and complicated areas to address when caring for families. Our traditional siloed system of prioritizing and separating mother's care from baby's care in some ways makes it easier to address when relapse or recurrence happens, which is that the pediatric provider doesn't ever know about it until often something else has happened and there may be a negative outcome. So we've really worked hard. And that was some of the slide that I had shared with you around how we think about recurrence of substance use and what is safety and safety concerns in order to help children not just be safe, but also to help children's well-being while parenting and potentially relapse or recurrence to substances. And that does involve partnership with our state child welfare reporting. But I do think that the best outcomes happen when it feels as though we've been able to develop a supportive plan to support women when recurrence of use or relapse occurs. That doesn't mean that our patients aren't fearful of that and that we haven't seen really bad outcomes. And so I think in the work that you guys do to continue to push towards a collaborative relationship with your child protective services agencies and move them towards a more sophisticated understanding of addiction and the disease of addiction is really important to doing this work.
All right, we had just a comment saying thank you for your passion and awesome presentation. Any final questions that you'd like to ask or any final thoughts you want to give?
I don't think so. Thank you guys so much for the opportunity to present and really please reach out to me at any time. I'd love to learn from all of you guys.
Thank you so much. And we wish you luck today. We hope you get to speak on behalf of the moms and the babies.
Thank you.
Have a great day. Bye.
Thank you.